In this video, we will have a brief overview of pancreatic cancer, look at the pathophysiology, the risk factors associated, symptoms and signs associated with pancreatic cancer, common investigations, and different management options. First, to cover some basics, pancreatic cancer is the 10th most common cancer in the UK and the 4th most common cause of cancer death. It most commonly occurs in patients aged 60 to 80 years old. And occurrence is typically equal between males and females with a ratio of 1 to 1. The prognosis of pancreatic cancer is often poor, with the majority of individuals presenting when the cancer is extensive. Now looking at the pathophysiology, there are a few different types of pancreatic cancer, with the most common being ductal adenocarcinoma of the pancreas. This arises from the cells lining the ducts which form the exocrine portion of the pancreas. They can spread out from the ducts and form anywhere along the length of the pancreas, from cancers of the head of the pancreas to cancers of the tail of the pancreas. Ductal adenocarcinomas make up 90% of all pancreatic cancers. Another type is that of ampullary cell tumours, so named as they form around the ampulla ovata, although these are still adenocarcinomas. There can also be neuroendocrine tumours of the pancreas, which are covered in a separate video. Now to look at some risk factors. Similarly to other cancer types, risk factors for developing pancreatic cancer include smoking, chronic inflammation of the organ involved, so in this instance, chronic pancreatitis, and by extension, anything that contributes to the development of chronic pancreatitis, such as alcoholism, and recent or late onset diabetes. Those diagnosed with diabetes after 50 years of age have an 8 times greater chance of developing pancreatic cancer over the first few years following the diagnosis. Now we'll review some common signs and symptoms associated with pancreatic cancer. There are a mixture of both systemic and local effects that pancreatic cancer can have. Due to general tumour burden and impaired digestion, the patient could experience weight loss, general fatigue, and overall cachexia. Other symptoms depend on the location and the extent of local invasion of the cancer. This can include abdominal pain, which can occur if there is invasion into nearby structures or due to concurrent pancreatitis, although it is important to note that they can often be painless, especially when compared with inflammatory abdominal pathologies, in which pain is often a prominent feature. For cancers of the head of the pancreas, it may result in obstructive jaundice, in which the common bile duct is compressed due to tumour invasion, resulting in obstruction of bile flow into the duodenum. The obstruction of bile flow and subsequent backflow will result in duct dilatation as well as gallbladder enlargement. There will also be an increase in serum conjugated bilirubin as well as unconjugated. The patient will be jaundiced, and as no bile can pass into the intestines, there is no production of stercobilin. As this is the pigment which usually gives stools its colour, the patient will have pale stools. And high levels of conjugated bilirubin in the blood lead to dark urine. Altogether, this is a picture of post-hepatic jaundice. On examination, there may be a palpable abdominal mass and/or an enlarged gallbladder, and upon palpation, this may be painless. Painless jaundice in the setting of a palpable mass is very unlikely to be caused by gallstones. This is known as Courvoisier's law, and in such instances, cancer of the head of the pancreas should be investigated. After clinical history and examination, investigations for pancreatic cancer can be split into laboratory and imaging investigations. Laboratory investigations include routine bloods such as a full blood count, which may indicate an anemia due to the malabsorption associated with the pancreatic cancer, liver function tests, which may be deranged due to biliary involvement or obstruction, urea and electrolytes, which may also be deranged due to malnutrition, and checking for the presence of CA19-9. This is a tumour marker that is highly specific for pancreatic cancer, although it is mainly used for monitoring the response to treatment as opposed to initial diagnosing. It is important to note here that there may also be a raised CA19-9 in cholangiocarcinomas. Due to the location of cholangiocarcinomas, they may also present with a very similar clinical picture. Hence, when pancreatic cancer is suspected, cholangiocarcinoma should be high up on the list of differentials. With regards to imaging, investigations typically done include an abdominal ultrasound scan, which can be particularly useful in demonstrating changes to the gallbladder or biliary tree, a pancreatic protocol CT, which is also a CT angiography of the vessels surrounding the pancreas. This is an important imaging investigation as it shows the extent of the tumour as well as potential invasions to surrounding vessels. Vessel involvement will determine whether or not the patient is suitable for surgery. A general staging CT can also be done to check for spread, which is then classified via the TNM staging system.
These patients also need a PET CT as per NICE guidance.
In addition to this, brushings of the pancreatic tumour can be taken via an endoscopic ultrasound or via ERCP. Now we'll go over the general management of pancreatic cancer. Typically, surgery is the only curative option, and procedures will vary depending on the location of the tumour within the pancreas. If the patients are suitable, cancers of the head of the pancreas will generally be treated with a Whipple's. The details of this procedure are covered in a separate video. Cancers of the body or tail of the pancreas can be treated with a distal pancreatectomy along with a splenectomy. Eligibility depends on the stage of the cancer, including vessel involvement. Chemotherapy is often used as an adjunct to surgical treatment. It is usually in the form of adjuvant chemotherapy, i.e. chemotherapy after surgery, of which a commonly used drug is 5-fluorouracil.
Neoadjuvant chemotherapy is also used to downstage borderline or locally inoperable tumours at presentation, as long as they haven't metastasized.
In metastatic disease, a common combination of chemotherapy drugs can be used. This chemotherapy regime is known as the FOLFIRINOX regime and is made up of 4 distinct chemotherapy drugs: folinic acid, 5-fluorouracil, irinotecan, and oxaliplatin. The majority of patients with pancreatic cancer are not candidates for curative surgery, but instead require palliative care, which principally addresses the symptoms and complications associated with pancreatic cancer, and includes analgesia, replacement of pancreatic enzymes with creon to aid against malabsorption, and ERCP with stent implantation for those with biliary tree obstruction. Here, a camera is passed down the digestive tract until it reaches the ampulla of Vata. A wire is then inserted into the ampulla of Vata and then is advanced up the common bile duct. A stent can then be fed over the wire and expanded. It remains in situ and allows bile to pass freely into the duodenum, thus relieving biliary obstruction and any symptoms associated with it. Stenting via ERCP can also be done in curative cancer patients to relieve symptoms prior to surgery. With regards to prognosis, pancreatic cancer has a high metastatic capacity even in small tumours. Pancreatic survival rate remains poor, with overall 5-year survival being less than 5%. To summarise what we've covered in this video, briefly reviewed the epidemiology of pancreatic cancer, looked at the pathophysiology and different types of pancreatic cancer, including ductal adenocarcinomas and pulmonary cell tumours and touching on neuroendocrine tumours, risk factors such as smoking, chronic pancreatitis, alcohol, or late/recent onset diabetes. Signs and symptoms associated with pancreatic cancer at both a systemic and local level. Investigations, including routine bloods, the CA19-9 tumour marker, pancreatic protocol CT, and a standard staging CT. And overall management, such as a Whipple's procedure, a distal pancreatectomy, adjuvant chemotherapy, combination chemotherapy regimes, and palliative care.